Well, good. We'll go ahead and start the meeting. And first, I have to thank you all for taking time out of your busy schedules to come and attend this meeting. Today, it's about lung cancer. It's all about lung cancer. And it's the Living with Lung Cancer program. This is presented by the Florida Society of Clinical Oncology. My name is Dr. George Simon. I'm a thoracic oncologist by profession, and I do some early drug development. And I'm a professor of medicine at the H. Lee Moffitt Cancer Center in Tampa, Florida. And my specialty, as you can guess, is thoracic malignancies, in particular lung cancer. Tonight, I'll be your moderator. And we have a very special panel here. And I'll be introducing each one of them as we go through our evening. If you have any questions, please feel free to ask. You can even write it down on your index cards and give it, and I'll be happy to ask those questions for you. Now, the part of to give you a little bit of an introduction on FLASCO, Florida Society of Clinical Oncology, it's a statewide nonprofit organization committed to facilitating and promoting multidisciplinary efforts to promote and improve patient care in Florida. A part of FLASCO's mission is to act as an advocate for Florida cancer patients and their families and caregivers. And it is within this part of our mission that we are providing this patient advocacy educational event this evening. Now, the goal of this is essentially an outreach program to promote patient advocacy and to bring together cancer patients, cancer survivors, cancer caregivers, oncology experts, and corporate supporters to learn and exchange information about cancer. So this program is supported by a generous grant by AstraZeneca, and thanks to AstraZeneca for their support and dedication for patient education. After the event, please stop by. They have a booth here to pick up some additional resources and materials. And they have important and pertinent information pertinent to lung cancer. I'll also like to inform the attendees that today's program is being recorded and made available to the community. And so those who were unable to attend will be able to watch these recordings. Now, there are, as I mentioned earlier, there are these index cards where you can write down questions and hand it over to me. And then we have the luxury of having an expert panel available to us to answer all your questions. Now, let me begin the program today by inviting our first speaker. Our first speaker is Dr. Tyrell Johnson. He's a medical oncologist and a lung cancer expert from the Orlando Health Program and Facility. And Dr. Johnson is an acknowledged expert in the field. He probably sees more patients than I see in a month. And he definitely has the experience to back up his statements. So Dr. Johnson will be talking to us about lung cancer, the disease. Dr. Johnson.
Yeah, now I'm on. Okay. All right. So this is very informal. So if you have any comments or questions, feel free to ask. But I think for a community setting, we just want to talk about what is the scope of lung cancer. Okay, so initially when I started in oncology, and I know I look very youthful, but you know, exactly. We thought of lung cancer as a disease of just smokers, okay? And lung cancer has always had the stigma that it is a self-induced disease. And so therefore, when I first started, research resources for lung cancer fell way short of many other disease states, okay? So as I've progressed in my career, we've seen kind of a switch in our thought process about lung cancer. Lung cancer has become like the poster disease for many other disease states. Lung cancer has been far ahead of other disease states as far as incorporation of next-gen sequencing, looking at the genome of the patient and tailoring treatment towards patients specifically based on what their genetic signatures are. So that's been quite, a revelation during the course of my career. We know that there are going to be about 30 some odd % of patients who will develop lung cancer who are never smokers. Okay. So I think the other part of lung cancer that we still fall short on is diversity in clinical research and continuation of patient advocacy. Okay, so when I kind of make a blanket statement of what is lung cancer is a disease that encompasses a multitude of patients, multitude of family members, and a multitude of people who need to help out in research, strengthening patients, strengthening families, and progression in our knowledge of the disease. Okay. So those are the main thoughts. I know this is kind of a interactive forum, so I don't know if there are any questions or anything that myself or Dr. Simon could answer in the regard of lung cancer. If not, then I'll keep talking. Okay. All right. So the next thing I want to say about lung cancer is, and Dr. Simon will be able to comment on this also, is in lung cancer, I think we are at the cutting edge of, things that we look at in research also. Okay. Always trying to progress our knowledge in the field. So having an early phase unit, there are a lot of interesting studies that we hope will be beneficial to patients. We're looking at studies for mRNA, making vaccines that are tailored towards the patient's particular tumor. We're looking at different forms of how to make our immunotherapy better. We're looking at different studies to see how we can look at the patient's, molecular structure and tailor our treatments to make it more efficient for that particular patient. Okay. So we want to continue our efforts in research. We have to engage the community because the community and the patients are the backbone for everything that we do. Okay. So advocacy, research, and then I know further down the line within this talk, we're going to talk about how can we help patients? How can we get them to resources? How can we give them information so that they can empower themselves, have advocates, but also be their own advocates? Okay. All right. Questions from anybody? Yes, ma'am.
Question.
Yes, ma'am.
What's the correlation between and them getting lung cancer? have had two students that is breast cancer, and then found out 4 or 5 years down the road after that breast cancer, tumors in there, a tumor in the lung.
Sure.
Any correlation that we've seen?
That's a direct correlation, whether they had some, genetic syndrome or sort. But we also know that, if you have a cancer, you have a 10% or so risk of having other malignancies. Then you also have to think about, we do well with treatment, but treatment is without side effects. So we also have to look at, do our treatments down the road, including radiation, are those factors in, creating a biome that's more, sensitive to having other malignancies. So it's kind of multifactorial. So I don't know what it was in particular for them. But, we do have to take into account, what our genetic structure is and what we do when we give a patient a particular treatment. Okay. All right. Okay. Oh, sure.
To increase diversity and then the other part of that is, what would you say is the biggest challenge?
I attended a conference recently, and we were talking about diversity in clinical trials, and what the thought process was, and I know I gotta hurry up, is patients, if you give them the information, if you tell them why we're doing the research, what are the benefits, what are the cons, patients tend to want to do clinical trials, okay? But you have to get them the information. So we are trying to do better as far as locating patients and telling them, these are your options. And then we also have to do better at keeping it in the front of our brain before we start treatments, to look and see, are you eligible for a clinical trial? Is that better than the standard of care? And so it's kind of teaching the patient, but you also got to teach the physicians too. Okay.
Thank you for that. To answer your question, the biggest reason a patient does not enroll on a clinical trial is because the physician did not offer it. It's the single biggest reason. And I was working in a unit where about 50% of my patients were minorities. And I had no trouble enrolling patients to clinical trials. I saw these patients, I offered them clinical trials, and they enrolled just as enthusiastically as the non-minority population. There are some challenges, though. The patients that I see are Moffitt are often affluent. They're able to travel. They have the resources to get on a plane or drive long distances, rent hotel rooms. And some of our minority patients may not have those kind of resources. And so they're not able to travel and board planes and rent hotel rooms to access the latest in clinical trials. So the solution is you bring clinical trials to them. So having a wide network of clinical trials available so that we bring clinical trials to them. Once you accomplish that, I had no trouble enrolling patients, minority patients, to clinical trials. And so that is not an issue, and that is a very important point, because we need our clinical trials to represent the broad population. And so it is important that we increase access to minorities and enroll more and more minority patients to clinical trials. So Dr. Johnson, thank you very much for that brief and succinct presentation. Lung cancer is the second most common cancer in the United States for both men and women. breast being the most common in women and lung being the most common in men. In the last 10 years or so, we have had a dramatic improvement in cancer-related mortality in the United States. And I'm proud to say that the vast improvement is because of the improvements that we have made in lung cancer. Firstly, there has been a big decline in the incidence of lung cancer. And that's because of a dramatic decrease in smoking in the United States. In the 1970s and 80s, about 42% of the American adults would smoke. Now it's down to somewhere between 15 and 16%. And smoking rates among teenagers is now down to about 12%. So in a few years, we will be having smoking rates in the vicinity of 10%. So one of the biggest reasons why we are seeing an overall decrease in cancer-related mortality in the United States is because of the decrease in lung cancer incidence secondary to smaller smoking. We'll see much bigger impacts. Cancer takes 10, 20, 30 years to evolve. So we are seeing lung cancers that from smoking habits from 10, 20, 30 years ago. So we'll obviously see much better improvements, decrease in incidence. The second most important reason why we're having such a high improvement is because of the improvement in our therapeutics. Our surgeries have gotten better. Our medical treatments have gotten better. We have targeted therapies, immunotherapies. There are several people here from companies that make those products. And previously, when I was a fellow, the chances of the 5-year survival from lung cancer was 8%. Now the 5-year survival from lung cancer is closer to 30%. This includes stage 4 patients. Okay. And I would like to sort of take this opportunity to address one of the myths in cancer is that once you have cancer, you're done. It's not curable. That is not true. We cure the vast majority of our early stage patients. Stage 1, if you're properly staged, 90% cure rates. Stage 2 is closer to 70%. In stage 3 and stage 4, where we didn't have any cures, we are still seeing significant improvements in survival. And in many of those situations, we are able to convert an incurable disease into a chronic one, something that you live with. And as you can see, most of the diseases in internal medicine is not curable. We don't cure diabetes. We don't cure hypertension. We don't cure chronic renal failure. We don't cure coronary artery disease. We don't cure hyperlipidemia. We don't cure arthritis. We don't cure dementia. We don't cure anything. We cure a few infections here and there, right? But we teach our patients to live and with these diseases for a long time. And lung cancer, I'm happy to say, is progressively becoming one of those such diseases that if you're diagnosed in an advanced stage, we can significantly improve survival and convert an incurable disease into a chronic one. But we cure the majority of our early stage patients. Using that as a segue, I have the proud privilege of introducing Dr. Kojo Dadzi. He's a surgical oncologist and the Orlando Health facility. And as you know, most of the cures from early stage lung cancer is because of our surgeons. They do all the hard work and we just take the credit for it. Kojo, please.
Thank you. Thank you very much. I think it's actually the opposite. You guys do all the hard work and we get all the praise and we get all the glory, but it's definitely a team effort. Thanks for having me. Like Dr. Simon said, I'm Kojo Dadzi. I'm one of the thoracic surgical oncologists over at Orlando Health. And I'm here to talk about, when someone gets diagnosed with lung cancer, the first thing that they think about is, I want it out. They want to see the surgeon and just cut it out, regardless of what it is. Okay. So that's when we come in, we do a lot of education. We work with our medical oncologists. We have a whole team of people that we work with to try to figure out the best treatment plan for our patients. And this is because we don't want to treat every patient the same way. We want to make sure that every patient is getting, an individualized sort of treatment, a treatment that really caters to them and their needs. So when someone gets diagnosed with cancer, the first things that, every physician that is involved with the care will try to do is to stage that patient. And you hear, everybody going about, oh, I'm in stage 1, stage 2, stage 3. That's what we try to figure out, because that really determines what kind of treatment algorithm that you go under, whether it involves surgery from the beginning, whether it involves surgery at a later time, or whether you're just going to need some sort of systemic therapy or some local therapy, and that will be all that you're going to receive. Now, we also have all this immune, therapy regimens that we can give our patients as well. So staging is very important. And we have a lot of modalities that we use to try to stage our patients, from just getting CT scans, from getting PET scans. And also sometimes if we see anything suspicious with the lymph nodes, we might want to see if there's any spread to the lymph nodes prior to, getting a final stage, clinical stage, prior to any sort of treatment. So staging is very important. When I come in, some of the patients, I'll say, let's say 50% of the patients that we see already have a diagnosis coming in, and maybe the other 50 have a nodule or something, that a mass or something that they saw in the lung, that they referred the patient to us to start off with. So we see anywhere from, diagnosis and workup being done to patients that we're about to start the workup from scratch. And the way I will focus a little bit more about how surgery plays a role. So actually we can play a role from anywhere from the biopsy all the way to even patients that don't necessarily need surgery for, curative intent. So we can do certain procedures that can help palliate some symptoms that they have from their cancer, even if it's advanced. So as far as biopsy, we do work with our interventional pulmonologists a lot, that they have a lot of, minimally, procedures that they do using like the bronchoscopy to try to sample these nodules or these nodes that are seen in the lungs to help give an answer of what it is. Once we get an answer, sometimes they don't get a, definitive answer, that we have to go in and do a surgical biopsy. So there are certain times that, a patient will go in, have an attempted biopsy, and still get sent to the surgeon for a surgical biopsy, which we go in, we identify what the nodule is using imaging and what we see in the operating room. And we take just a little piece of that lung out and send it to the pathologist for review. So that is one role that a surgeon plays. Another role that a surgeon plays, like Dr. Simon was saying, is with people with early stage lung cancer. And with most of these patients, surgery alone can be curative. So what we do is, after we stage the patient, make sure we check to make sure there's no spread anywhere else, and they're they end up with a stage that is quite early, we can go straight towards the surgery and take a piece of the lung out. We can take a smaller piece of the lung out. We can take a lobe. The lung is divided into little different, sort of portions. So we can take a whole lobe out, or even sometimes in some patients, we can take an entire lung out to try to, give them the best overall survival moving forward. So we have different options in that way of us trying to get the cancer out. And also there are some patients that have advanced cancer that has, spread, or they have cancer that has built up fluid that has built up around their lungs that has cancer cells in it. And we can also do procedures in that sense to try to help with their symptoms. So we call that palliative sort of treatment, that will go in, We can drain the fluid out. We can leave a little catheter in that they can even go home with and have nurses come home and drain these fluid out, giving the lung time to, re-expand and fill up the space. And we can even put some medication around the lung and in the chest to make it stick to the chest wall so that they don't have the fluid come back. So we do play a quite extensive role in different, parts of the treatment when it comes to our patients that have, unfortunately been diagnosed with lung cancer. Now, I think one good thing that we're doing that we are all really proud of from the surgical standpoint is we're doing this single anesthesia cases. So basically what that means is you come to the hospital, you get your body, you go to sleep from the anesthesiologist will put you to sleep. We do the biopsy, and based on the results, you can get the surgery during that same procedure. So you don't have to come in. We know most of our patients have a lot of anxiety with the diagnosis of cancer. So coming in, having the biopsy, going home, waiting for another 2 weeks for the results, coming in, seeing the doctor, going like, yes, it came back positive, I have to do surgery, I need A, B, and C, going back, sitting for another 2 weeks to get you on the schedule before your surgery. That's almost a month, which when you have cancer in your body, you're trying to get it out, but also being stressed and having all this anxiety. So sometimes we can, have patients come in, we do the biopsy, and while they're still asleep, we go ahead and take it out if it comes back negative, if it comes back positive. If it's negative, we stop, we don't do anything. And then whenever they wake up, we have a discussion with them and their family, knowing that, there was no cancer, we didn't have to do any surgery. So that's something that we've been offering our patients, and I think is going a very long way. We do most of our procedures with a robotic system now, with minimally invasive. So you have really, really small incisions in your side. That really helps with post-operative pain. That really helps with shortening length of stay. Most of our patients are leaving the hospital in about 2 days after getting a part of their lung removed. The last thing that I would like to say is, unfortunately, not all our patients that we see walking in the door with lung cancer are good surgical candidates. So there are other treatment, modalities that we can offer as well if we feel like you're not going to be a good surgical candidate. Because everything that we do has risk, including, the chemotherapy, the immunotherapy, the radiation. But as a surgeon, what I want to do is make sure that what I'm doing, the benefit is like way up here and the risk is way down here. If the benefit outweighs the risk and it's right in this range, maybe, not so good. So, my primary goal is not just to get the cancer out as a surgeon, but to make sure I'm able to get you back to your family as well. So that is an overall broad overview about, what surgeons do, the role that we play, and I'll be very glad to take some questions.
Johnson. Oh, thank you. And Dr. Simon. Good to see you, Dr. Simon, by the way. So in this era of neoadjuvant chemo IO pre-op, how do you decide who the best patients are for the single anesthesia technology? Is it clearly when the nodes are negative and you can then go directly into the surgery and the patient's a 1A, 1B, or how do you make that decision? What if it's low volume preoperatively and they have a stage 2 on the EBA? So right. This is in the era of all of these new neoadjuvant studies coming up.
Yeah. So that is actually a really good question. So what we do is we try to get, most of our stage in our clinical stage, outright prior, to going down the line of this single anesthesia. So there's some patients that we see, in the office and, they want a surgical biopsy because regardless of what it is, they just want it out, whether it's benign or not. So there are some patients that will, since we're going to be doing surgery, we will probably get a PET to make sure there's nothing elsewhere. We're going for a surgical biopsy, do a small wedge resection. If it comes back as, cancer, then we can proceed, with doing a lobectomy and the mini-sentinel lymph node dissection. There's another group of patients that will come in, knowing that, they have a nodule or something diagnosed, and then we'll go in, just to, if it's in a good spot, just do a segmentectomy based on their pulmonary function, based on other factors that we feel like maybe they cannot even tolerate a lobe, or maybe they can even tolerate, some other form of treatment. So we'll go ahead and, offer them, surgery up front. As far as the single anesthesia per se, I think what that has done is it saved patients from, that are maybe borderline with their pulmonary function test, to go in with a surgical biopsy, which is basically taking a piece of the lung out for benign lesions. So for the patients that come in that are a little bit, like I saw a patient today, never smoker, has like a 1.2 centimeter nodule, wants a biopsy of it. She actually wants it out. The son is the one that really pushed, for it to be biopsied first. So we do offer this upfront that we can biopsy it. If it's negative, we done. If it's positive, we can go ahead and take it out. With this whole neoadjuvant era of, doing some sort of immunotherapy, it is a very gray area right now that we're dealing with, trying to know which patients that maybe should complete all the staging, have some sort of neoadjuvant treatment, and then move forward with some sort of surgical treatment. I'll say I usually offer the single stage for the stage 1As and not the 1Bs.
Is there, I'm a patient, I just found out, what are like the most common reasons someone would not be a candidate for surgery, and how do you communicate that?
So some of the most common reasons is that the pulmonary function is not strong enough. So what we do is, like I said, one of our primary goals as surgeons is try to get you back home to your family. I don't think I do any patient any favors by going in, taking a piece of your lung out, and they cannot come off the ventilator because they cannot breathe by themselves. The cancer is out, but then I've really not done you any favors. There's no need for me to go in, take a lung out, and then now you like, some patients will need oxygen, for some time, but then for, permanently be on oxygen, be debilitated, can't even walk from your bedroom to your bathroom without getting short of breath, then basically you've been very debilitated from the surgery. So we do have a test that we get to make sure that will give us a good idea about how your lung function is before and after surgery, with the planned intent of which part of the lung we're going to take out. So we know whatever is remained, how strong that will be. There are other patients that have some other comorbidities. They can have some really bad heart. They can have bad kidneys. They can have a bad liver. So they can have so many other comorbidities that not just with lung surgery, but just puts them at a higher risk, with any other form of surgery. Like I said before, I don't want, my risk and benefits to be right head on. We want it to be very beneficial if we're going to go down that route. Yes, sir.
So, metastatic, there's no operating. But sort of along with Dr. Singh's question, with the advances with neoadjuvant immunotherapy and even targeted therapy, is there a thought that with some of these therapies in the patients who are metastatic, who do really well, may even have complete responses, that you then resect after that? Because if the goal in the early stage is to shrink it and then ultimately get them to surgery and get them out, right, if you have targeted or immunotherapy that gives a response to a metastatic patient to such where their lung function improves so much, their quality of life improves to where their tumor is so small that it could be operated, why is that something that, or are they considering? I haven't seen that yet.
Right. So as far as, patients that have complete response. So if they have a complete response, usually they don't need surgery. Okay. So meaning, whatever treatment they went under, whether it's chemo, immunotherapy, at this point in time, we don't have any evidence of them having, some sort of cancer. If for whatever reason, let's say everything, their markers are down, the tumor has shrinked, I think if you have tumor that has spread, depending on where it's gone, right? So if you have tumor that went to your lymph node, that is in the chest. That is still considered a spread. But we can usually, depending if it's not bulky, if it's a single station node, sometimes there are some patients that have, stage 3As that we can still offer surgery, to after the fact. There are some patients that we do our clinical stage, they seem to be an early stage patient. We take them to the operating room. We see a node, that looks suspicious. We send it to the pathologist for them to take a look, and it still comes back as cancer that we notice a spread that will still proceed since we're already in there and even complete the surgery, and they can have treatment, systemic treatment after. As far as patients that have had some sort of metastasis to, either a single solitary metastasis to like the liver, the brain, or patients that have had, multiple metastasis elsewhere, it depends. That's a very gray area. There are some patients that are young, that have like, a solitary metastasis somewhere that has been treated. They've had good response that we will, talk about it usually in a multidisciplinary setting to see if these are patients that we can move forward to with some other form of treatment plan, which might or might not include surgery. So those patients population is usually something that we do talk about a lot.
So I'll say that is the crux of lung treatment is we always want to be multidisciplinary. So every patient is a discussion. So it's a discussion between the radiation oncologist, medical oncologist, pulmonologist, surgeons, and treatment is, as you said, very individualized. So you want to be at a place where you can have a group sitting around, tailoring your plan to what your particular needs are, what your particular response was, how you started, what your markers are, et cetera. So it's a discussion for each patient. So multidisciplinary discussion is the crux of lung treatment.
So
Thank
can
you
I
so
one
much.
question, Kojo? So you can't do surgery, cannot. Patient is not strong enough or has issues with heart and lungs. What are the alternative treatments available to the patient?
So, some other alternative treatments include, what we call, SBRT or stereotactic, beam, radiation therapy. Others include chemotherapy, others include immunotherapy, or a combination, or one or the other sort of modalities. So it is not like if you come in and they tell you to go see a surgeon because you have lung cancer, and for whatever reason, as a multidisciplinary group, we decide that maybe surgery is not your best option. It doesn't mean we're going to leave you astray or you're not going to have any sort of helping hand. There are other modalities that we can, talk about. And there are some clinical trials that are even out there that sometimes we can even put you in as well to see if it helps.
Thank you.
All right. Thank you, guys.
So, I'd like to highlight 2 points that were made here. One is cancer care is a team sport. You need a quarterback, you need the wide receiver, you need a running back. Everybody have to put their heads together. The medical oncologists, the surgeons, radiation oncologists, pulmonologists, pathologists, radiologists. So it truly is a team sport where all physicians from multiple different specialties puts their head together to come up with the optimal treatment option for the patients. Thank you, Kojo, for that presentation. So the next speaker is me. You got to put up with me for the next 20 minutes. Did you get your coffee yet? So my topic is what's new in lung cancer, the future of lung cancer. So I'm going to, start dreaming a little bit, what's new in lung cancer. So, from a medical oncologist perspective, it's drugs. Our drugs are getting better. They're becoming more effective. Drugs are getting less toxic. I still get people walking into my clinic and say, I don't want to have chemotherapy. I don't want to get sick. I don't want to look sick. I don't want to lose my hair. And with modern chemotherapy, we now know that we can control nausea, vomiting to a very, very high degree. We have chemotherapies now or treatments now that you don't lose your hair. I tell my patients, if you have more hair than your oncologist, then you're pretty good. So I show them my bald spots. Like they say, God only made a few perfect heads. The rest he covered with hair. So our drugs are getting better. We have Jenny Seng in the audience here. She can vouch for this. We have targeted therapies, that are very effective. I mean, those are pills. When I was a fellow, we treated everybody with chemotherapy. And if you had told me at that time that we would be giving you a pill that would be 80% effective and control your disease for at least 3 years, I would say, I don't know what you're smoking. But it's become a reality today. If you have a mutation, that brings me to my first point. Our ability to look at the genetic code that drives the cancer has dramatically improved over the last 10, 15 years. Once we understand this genetic code, and once we know what mutation or DNA abnormality is driving the cancer, we can shut it down. We can shut it down with drugs. And we have very effective drugs. And some of them just got recently approved for lung cancer. So the evolution of our ability to understand cancer at the DNA level, at the molecular level, and once we have that understanding, we are able to use drugs to shut down those negative DNA, the DNA that causes the cancer to grow. We can shut it down. So that's, I think, and we are getting more and more drugs that are coming. We are having specifically antibodies that can carry drugs. I call them smart missiles or smart bombs. So previously we just gave chemotherapy for cancer. Now we have an antibody that is attached to a chemotherapy, and the antibody sticks to a hook on the cancer cell. That hook is only present on the cancer cell. It's not present on the normal cell. So this antibody hooks onto that hook in the cancer cell, delivers the chemotherapy that it's carrying with it right to the cancer cell. We call that antibody drug conjugates. And then we have also been able to manipulate the immune system to our advantage. One of the reasons why cancers are able to survive is because they escape the immune system, our body's immune system. And so now we have been able to teach our own immune system to go and kill the cancer. And very often, when that works, it works very well. And some of those patients have advanced stage 4 disease, and many of them are living 5, 6, 7 years. Things that were unheard of in the past. So our drugs are getting better. More recently, we have been able to teach your own cancer-fighting cells. We call it cellular therapy. Cancer-fighting cells, how to go find the cancer and kill it. So there are these T cells, there are these cells in your own blood that are designed to kill cancer. Sometimes we take them out of your bloodstream. We grow it outside your body. We teach it or modify it to find the cancer cell and kill it. And then we put it back into the patient. And those cells are then kind of like those marauders who go around the bloodstream, find the cancers, and are able to kill it. So There are T cell therapies. We call it CAR T cell therapies. And so those are some of the things that are already here, and we are going to get better and better at developing more of these drugs to find and kill cancer cells. So that's the therapeutics part of it. What else is exciting? Now, cancer treatment was previously more of a field of the biologists like me, and now it's becoming more and more a preview of a collaboration between biologists and engineers. And one of the biggest, more modern engineering fields that are going to change cancer treatments in the future is artificial intelligence. It's already here. And how is it going to help? AI, artificial intelligence systems, are going to read our pathology. They're going to look at the slides and tell you whether you have cancer and what kind of cancer you have. Okay? And these machines don't need vacations, and they don't have to sleep. They're more than happy to work in the weekends. And so they can work 24/7, 365 days. They don't ask for raises, and they don't throw tantrums. So, so in the future, we'll have AI-based systems that will be diagnosing cancer for us. We'll be diagnosing it. Secondly, they can read scans, and so they're able to read CAT scans, PET scans, and they're able to make diagnosis. Already we know that AI systems can read pap smears, right? And so in the future, and again, you do a scan and boom, boom, the result is right there. It takes them a few nanoseconds to read the scan. You don't have to get a scan and then wait for 2 days, 3 days, and have the radiologist read it and all of that, So artificial intelligence systems are not only going to help us with diagnosis and for staging, like Kojo was talking about, which is fundamentally important, but in many other avenues. It's being used to predict responses to therapy. If Dr. Singh is going to give immunotherapy to a patient, she has to first give it, and then she has to see whether it's working or not by doing a scan after a few rounds of the treatment. But there may be AI systems in the future, and there are already companies that are doing that will tell you that if you give this patient this therapy, it's got this much chance of working. There are these decision support tools that will help aid the oncologists in making better decisions. Like Kojo was saying, it's all about risk benefit, how much risk for how much benefit. So we want to optimize the benefit and minimize the risk. And we can use some of these technologies to help with help us make better treatment decisions. A lot of times the treatment decisions we make are based on information that sometimes is not perfect. We have some tools like a marker called PDL1 to help us decide whether a patient will benefit from immunotherapy or not, but it's not a perfect marker. Okay. So that's another area where we may be using AI systems for better diagnosis, reading scans, predicting benefit, predicting toxicities, and these can be very valuable decision support tools to help us make better decisions. Okay. Now, finally, we want to make, an ounce of prevention is better than a pound of cure. We don't want anybody to get lung cancer in the first place, right? And if they do get lung cancer, we want to find it early and treat it quickly. like using the keyhole surgeries Kojo was talking about. Okay, so by it's to a certain extent a healthy lifestyle. Cancer is a lifestyle disease, right? And now we have all these genetic tools to understand what we are at risk for. 23andMe and so on and so forth. They'll tell you you're at risk for the way you metabolize caffeine is this way. The way you metabolize that is this way. So wider and better interpretation and availability of our tools will tell you you are at risk for this disease. And then once you know that, you can try to prevent it by changing your lifestyle. Okay. Another big tool that is underutilized that's available today is cancer screening, lung cancer screening. We have shown through large studies that lung cancer screening saves lives, improves survival, right? We do a CAT scan, and we do the CAT scan and look for nodules. And then if you have a nodule, that's early stage lung cancer that has been picked up, and we can cure early stage disease very effectively. So this is already approved in the United States. And in the state of Florida, only 2 to 3% of patients who are eligible for lung cancer screening is being screened. Okay, so just imagine the number of lives we can save if we institute statewide screening and everybody who is eligible to get screened gets screened. Because we can find these nodules early and we can treat these nodules early. Okay, now that could be thousands and thousands of scans, right? But think about a future where you get the scan, an AI system reads it, it tells you whether you have cancer or not, and it can all be done very quickly, okay? But for now, all those who are eligible to be screened, should get screened. Talk to your primary care physician. There are also screening facilities that will do these lung cancer screening tests. Lung cancer screening is kind of like mammograms or like colonoscopies. Screening saves lives. And so if we have to make sure that this word is spread out statewide, and by increasing our screening rates, we can diagnose more and more patients early, and we can cure them. We'll keep Kojo very busy here. He'll have to work 24/7 for the next 365 days. So I think that's the next major advance, that our screening ways of screening, predicting which nodules are malignant, and we'll be using AI tools to do that. And then those things can be done very quickly, and the treatments can be done quickly. Now, maybe in the future, even CT screening may not be needed. We could be able to diagnose cancer on a blood test. So there are several companies that are looking at diagnosing cancer by a simple blood test. You draw blood, look for certain genes. Okay, it's not perfected yet, but there's lots and lots of people working on it. And based on the genetic profile of the tumor, tumor, sometimes we already use it in the clinic for understanding the molecular underpinnings of a patient with cancer who we know have cancer. So the tumor dumps DNA in the blood. We extract that DNA and we study the DNA to figure out whether there are mutations or not. And then based on that, we can do treatments, right? So that's called liquid biopsy. I order it on a daily basis. I'm sure Jenny and Tyrell order that on a daily basis as well. But we could move it up the line earlier in the schedule. And maybe one day we may be able to go to a clinic, get a blood test, and know whether you have cancer or not. And if you have cancer, which cancer? Do you have breast or colon or prostate? And these could be detected at early stages and therefore can be treated. Okay. So I think the future for cancer therapy is cancer is very bright. Our ability to diagnose them is becoming progressively better. Our ability to treat them is becoming progressively better. And hopefully one day, we are so good at picking cancers at an early stage that the scourge of cancer will be at least well managed for our future generations. I'm going to quit dreaming now, but I'll be happy to take any questions. Jenny?
How do you decide how to screen your non-smokers to try to catch those EGFR and ALK-driven? It's a conversation that our team has had with, Todd and the team here, and just really anybody who is passionate about lung cancer screening and saving lives and detection earlier. What do you tell your non-smoker patients, regardless of heritage? How on earth do you decide who's at risk?
That's a great question. So the backstory to Jenny's question. So Jenny asked the question, how do you decide which non-smokers to screen? Okay, as you know, lung cancer is a disease most commonly seen in smokers. 85% of lung cancers happen in smokers, but there is this 15% that happen in non-smokers. The vast majority, about 75% of the patients who are non-smokers who get lung cancer are actually female, women, And we don't know who are those who are likely to get lung cancer. Now, screening currently is approved for those people who are 50 years and above and who have smoked for at least 30 years, right? So those are the people who are now eligible for screening. And then there was an upper age limit. That means if you're above 70, you don't need to be screened. But all those things are being reworked. So now I think the upper age limit has been removed. We may now remove the 50 years age limit, a younger age limit. We may now reduce the number of years that need to be smoked. But then what about non-smokers? 15% of a large denominator, as I said earlier, lung cancer is the second most common cancer in men and women. It's a large denominator. So 15% of a large denominator is a big number. So, Jenny, I don't know the answer to that question. I think, what I would do is patients with a genetic predisposition, some kind of a BRCA1, BRCA2, leaf-raminis, certain genes that they have, that could predispose them to get lung cancer. Patients with a family history of lung cancer, multiple generations, father, grandfather, grandmother, they could get screened potentially. Patients with a first-degree relative with cancer, they could potentially be screened even if they are non-smokers. These are some hypothetical things. And so, basically, if you don't have a habitual risk like smoking and drinking, but you could have a genetic risks, and then identifying those genetic risks, would be a way to pick out patients who could be screened. Yes, please.
So we all talk about, first-hand smoking. Somebody is smoking. But as a navigator, I come across many patients. They never touch a smoking in their life, but their loved one around them who exposed them to secondhand smoking. And they don't have a cancer yet, but they got diagnosed before the one who was smoking. So is there a room for secondhand smoking? Because I think it does come up very often when I see patients.
It's a great question. So if you have been exposed to secondhand smoke, if you grew up in a household where your parents smoked, or you have a spouse or a partner that smokes, then your risk of getting lung cancer is about 30% higher than the general population. So it is higher, and we do not have any screening recommendations regarding that. I think it's one of the things that we have to think through and see whether we should extend our recommendations screening to patients who have had long history of secondhand smoke exposures. It used to be a problem in air hostesses or hosts. They previously smoking was allowed in airplanes, and many of them have never smoked themselves, but they worked in close confined spaces for many, many, many years. And many of them have then eventually got diagnosed with lung cancer. They never smoked. Their passengers smoked, right? So yes, lung cancer is secondhand lung cancer is a definite, secondhand smoking related lung cancer is a definite risk. And it should really be on the radar screen, especially if the primary care physicians feel that there is any potential. It's maybe reasonable to get a CAT scan in that setting. Any other questions? If not, I'd like to hand the baton over to our next speaker. And this, who is that? Is that you, Dr. Patel? Oh, yeah, yeah. So our next speaker will cover the many patient assistance programs that are available for you. In addition to, we'll discuss the topic of the role of the caregiver. I couldn't emphasize this enough. We focus a lot of attention and resources to the patient, but what makes everything tick is the caregiver. And I often, feel that we do not give the caregiver the credit that they need. And they deserve, and the appreciation that they hold the thing together. They look after the finances, they look after the kids, they look after the household, and then look after the patient and still go to work. Some of the most inspiring people I've met in my life are the patients and their caregivers. They inspire me every day for the tough times that they go through, but they do it with such resilience, such grace and dignity, And so it's my pleasure and my privilege to invite Dr. Kinjal Patel, and she's from the Florida Cancer Specialist, and she'll talk about support, financial assistance, and caring for the caregiver. Kinjal?
Thank you. Good evening, everybody. Thank you, FLASCO, for having me here. And I hold a small place in this. And I like Dr. Kodro keeps saying that, it's a teamwork. When I see a patient as a navigator, we see as a provider patient for 15 and 20 minutes. And I tell my patient, I'm seeing you for 15 minutes, and it's very hard for me to judge you for remaining 23 hours of your life. When they come to the clinic and, I'm here for my treatment, they might just put up a smile on their face because they want to be that ideal patient and do not afraid to ask a question. So when that happens, I do tell patient, it's about you. End of the day, you have to make decision what works for you, because I do not know what you're doing in remaining 23 hours. And the only way I could help you is by providing education and information, but I would not know unless you ask me. And that's where the journey starts, the two-door conversation. When patient comes very first time as diagnosis of the cancer, the main thing I see is a 4 kind of a hurdle. If I would say it, it's emotional, financial, care coordination, and the nutrition. Most of the time, patient does not like to mention about finance because they feel like I'm here to just get a treatment. But finance is something affects treatment decision, not only the payment of the treatment. Also, there is a time when patient has to decide, am I putting a food on the table by going to work because I cannot get FMLA, or I'm going to get a treatment and there's no going to be food on the table. So when patient comes, as a navigator, I like to assess all those barriers to the care. And I empower them, saying that when somebody says navigation, what comes in your mind? It's a GPS. That's what most of the people say it. And I tell them, as a navigator, I'm that GPS. I will walk through this journey, but you will be in the driving seat. I want to empower you. But you could always look at your GPS and ask, I'm lost. Where are we going? Is this the time I need to call physician? Or I need more education to empower you so you could continue this journey? I do not know exactly where and how. If I don't know, I'll tell you, okay, let's take a detour. Not everything has to be the plan. This is the exact way to go, because everybody's different. Some people like to drive on the highway, and some people prefer to take a local road, and some people prefer to take tollways. So what works for you? And that, as a navigator, I'm here to support you. As a navigator, if I see it takes a villages, surgeon, medical oncologist, radiation oncologist, clinic nurse, scheduling staff, pathologist, all to care for that patient while they are in oncology center. When they go home, is that just one caregiver doing all that behind the background? So to me, caregivers are like a pillar to that system. And as a navigator, I want to keep that pillar stronger. And the way it could be done is by providing resources, to opening and having that trust building with them, that I'm here to help you, not to judge you, because goal is what is best and works for you, not as a navigator or provider what works for me. So Dr. Simon mentioned about the, people traveling to the center and sometimes financial burden. So there are resources available in the community. American Cancer Society is one of them. They do provide resources to patients for lodging. There is a resource called Angel Flight, which helps patients to cover the flight fare if they're going for their treatment. So when you go to see those physicians and you have those questions, I would say utilize your social worker, your navigator, your clinic nurses. Ask them like, hey, this is my concern. Who could help me? And most of the time, patient, when they're in treatment, they say, oh, I have a chemo brain, I forget. I tell them to keep a diary. It's like it not just only to help you remember everything, but also empowers you. So for example, on the treatment of a day 3, I started feeling nauseated on my first cycle. So when your second cycle comes in, when you're feeling nauseated, and that diary could help you when you to take your as needed nausea medication. Or I felt had a weird, funny feeling. You note it on the diary, but when you go to the physician, you could let them know and see if it needs to be investigated. Maybe you had a blur vision out of, side effect, or you lost a balance. Maybe a minor subtle sign, but it might be important for physician to know. So writing down the questions and keeping a diary. That diary also helps when caregiver needs a break. And I'm very strong advocate that if caregiver is taking care of everything, it's okay to take a day off. It's okay to take a help. Sometimes just asking a friend to watch a patient, and you could have a trip to grocery store without worrying, knowing that your loved one is in better hand. Or just having a nails done. It sounds very small, but it does recharge. And that time that diary does come in handy. That diary has information like what you're taking, your doctor appointments, your important phone numbers. So if something happens while you're not there, you're empowering the person who's watching them. And then communication. And we all sitting here, and please tell me if I'm wrong. I have seen that battle many times. Patient stays strong because they do not want to tell the caregiver, let them caregiver feel that I am tired or I'm, feeling down. And same goes for a caregiver. They stay strong for a patient. They don't want them to feel that, oh, I'm burdened. But some point of time, it's nice to have that one-to-one conversation, the communication. You be with your loved one for such a long period of time. Sometimes you're not saying, but they understand it. And those words needs to be spoken, and just tell them, no, like, hey, I'm having a rough day. And because of that feeling and you're trying to hide, it comes in a behavior. Sometimes we see patient comes and they're angry and they would be like, I'm frustrated, but then end of the day, they would say like, I'm not mad at you. I'm just mad at situation. To help them with that unspoken word. And that's when I say about the behavior health. Anytime when you say behavior health, patient does not want to hear it. As a caregiver, they do not want to hear it. And I would say like, let's not talk about the behavioral. How are you feeling emotionally with all this? So anxiety comes in, but patient, it just got today, a patient called saying that my heart rate is 170. And as a nurse, when somebody says your heart rate is 170, I'm like, what? And then as you start talking to them, asking those questions to rule out, oh, my heart rate is 70 now, I'm perfectly fine. No chest pain, no dizziness, nothing. I'm perfectly okay. And that's happens very often. The anxiety comes in and we don't like to talk about, patient does not like to say that, okay, I'm anxious. And so having that, the moment of availability, the resource in community, like how to channel that anxiety, maybe just having part of a support group, the local support group, speaking with the social worker, the community, if you're involved religiously in the church, talking to the friend. If you do not want to talk to friend and family, you could ask the provider, I'm having these feelings. Can I speak with somebody? Can you give me a referral? Or there is a resource in the community, we could do it. And that helps. So I do feel that communication is the key. And going back to the caregivers, it's that pillars need to stay strong. The way it's like communication, it's a two-way street. Talk to the patient, you love them. They understand you the same way as they do. And take that one day, maybe a half an hour to the grocery. And that helps because as a care team, we can care for a patient when you're with us for that limited period of time. But when you go back home, you are that person to whom patient relies on. So I would, encourage to have that conversation with them. And it's okay to ask for help. As a human, we don't like to ask for help. It's in our nature. I want to stay strong, but it's okay. It takes a stronger person to say, I need a help versus just, taking all it in and waiting till it gets okay. It's not bearable. And same way, it's okay to ask a question when you see your physician. I have worked with no single physician which would say that, why are you asking me that? All of them who are in oncology field, they are compassionate of what they do. And when you ask those questions, you're not just empowering yourself, but you also somewhere addressing that anxiety of fear of unknown. When they hear from physician what they're doing, why they're doing, it helps to address the anxiety comes with it. So I would leave there. Any other questions, concerns, or something I missed it and have it to chime in? Sure.
Sorry, I don't know if this question is relevant here or you're the right person to answer this, but is there any financial supports available to those patients who do not have insurance or who are here on a travel visa or something like that? Because I have had patients whose loved ones had cancers, and back in the home country, they do not have the right treatment. And here we have treatment, but there are so many barriers to those treatment because of their visa status and insurance. So I don't know if this question is relevant here, but I apologize.
No, no. No. So as a navigator, I see very often, and it hurts when, like, I know I can't help it. There are some legalization, and the reason behind it is because it's funded by government. You know what I mean? There are charitable association in here, like, in local and in Tampa, but there's still, again, it's a qualification part. Like, yes, they could go to emergency department, and emergency need can be taken care. So if it was a life-threatening and they were in emergency department, they will be taken care. But if it's something like heme patient traveling across the globe to United States to get a CAR-T transplant, that won't be covered unless patient is financially, supported, because that's something, like, I am at a hard spot to say it, but that's the one of those things, like, I want to help everybody, but as a navigator, I can't help everybody.
Question I've got is, if you offer Thanks. If you're an academic center-based healthcare provider, you're pretty much specialized. You get to do this stuff all day. And so you learn a lot more. You're up on the technology, you know what's available. You've got the ability to have the multidisciplinary tumor board discussions. In the community, it's unbelievable because they have to know how to treat everything. And they don't get, a lot of times, they might choose one tumor board if they're even involved with any of them at all. So as a nurse navigator in a community-based practice, if you know that a certain patient is seeing a physician who doesn't necessarily get a chance to participate in local tumor boards, and we know that most education occurs after a diagnosis, not before, how do you interject in that care to help make sure that everything that could be done for that patient gets done to assist your medical oncologist?
So most of the time when patient comes right after diagnosis. So based on the diagnosis, I want to make sure the staging is complete. So, like, I don't have expertise what physicians do, but I would just reach out to ask if it's like, are we getting MRI done? Okay, are we ordering genomic mutation? Is this patient going to see a radiation oncologist? It's a very feeling of that to be a team player. It's not about poking that, oh, you forgot this or something is not done, because end of the day, we all want to have what is best for a patient. Patient is taken care in the best possible scenario, and every patient is different. Like, there is no single box which fits everybody. So it's based on a scenario. I usually reach out to the physician and advocate for my patient. It's nothing that if it's one of those things, yes, tumor board is not available in the community. I totally get it, but that's where patient wants to get treated. And when patient wants to travel to academic center, nothing wrong in it, but like Dr. Simon stated, there are other barrier comes with it. So patient choose to be in community. When they're in community, we try to make sure they have a best available, including a clinical trial. So, and that's when I was saying, like, I know a couple of my patient, their clinical trial at Moffitt, but they getting treated in community. So what they do, they getting treatment closer to home, they go to Moffitt, see what they need to when they come back. So it's make the best out of what you have. There is no like standard or straight road. Every patient is different. So like it's still a collaboration with physician and nursing staff and patient's willingness. Does that help?
Thank you, Kunjal. Yeah, so I'd like to, there are resources available, and especially if there is a targeted therapy that needs to be given, there are many of the pharmaceutical companies have programs where they give you a drug. And many of the institutions have have programs where they'll give you, care, no cost care. They won't charge you. So many institutions have these charitable patients where they don't charge for the scans and doctor visits, but they'll get free drug for you through AstraZeneca. They have an AZ and Me program where if you are under-resourced, they'll provide the drug free. So there are many such resources through the pharmaceutical companies and also through institutions where you can get free care and free drug in under-resourced patients. And then to sort of just detail on what you asked, 85% of the patients get their care in the community. 15% of the patients on an average get their care in academia. But academia has got all the resources and the specialized expertise, right? How do we extend that expertise into the community, and how do you make that available to the larger cancer community? And so it's a partnership. Academia has to work in partnership with community patients. How does that work? Well, sometimes in difficult cases, in rare cases, in difficult situations, often they come and see people at Moffitt or other institutions for an opinion. And then a treatment is crafted, a treatment plan is crafted. And if that can be done locally, the patient is sent back to their primary medical oncologist who delivers the treatments locally. And so it is a partnership. Some of my patients have to drive 3 hours to see me. I said, if I can do this treatment, if your oncologist can do this treatment 15 minutes from your door, and here's the treatment, here's the strategy, here's what you do. I call the oncologist over the phone and, convey the recommendations, and they get the treatments locally. And then they come back to academia. Virtually the only time where I keep patients in Moffitt is when there is a clinical trial or there's a drug that's available only there. To me, that's the only situation where it justifies keeping patients in academia. But once you craft the treatment plan, you send the patient back to the primary oncologist and then tell the patient, our doors are always open. You can always come back anytime. Things are not working, come back. We'll be happy to reevaluate. Okay. So does that answer your question? Okay. Our next speaker is Kim Friedman. This is going to be the most fun part of the whole evening.
Also,
And she's going to tell us about mind and body balance and chair yoga.
allow yourself just to move your shoulders up and down. Okay. Just slightly. Okay. Move them the other way. All right. Just simple movements like that can relieve stress. So now you can. I've been teaching oncology yoga at Advent Health in Daytona Beach since 2019. I believe in what we call integrative therapies, which means yoga, massage, acupuncture, Reiki, and maybe even aromatherapy. These can be complementary to our Western medicine, which really is the one that helps it cure. But you all know, and a lot of you are the medical professionals, that, and it's been heard several times about anxiety, and that's where yoga can come in. We teach our people to breathe. Simple. Just allow yourself to be that breath, to use the breath to help calm the mind. Because we all know our mind goes in those negative places. It just does. We get anxious, the heart starts to race, the butterflies start in the stomach. And so when we can use the breath to calm those down, we're allowing our system to work properly again. So that's where we are. We also know that we need movement. Life is movement and movement is life. If you're in pain, what is the first thing you want to do? Get in your bed, put your covers up by your head, and we don't move. That doesn't improve our immune system, doesn't help us help ourselves. So in chair yoga, we stay in our chairs, but we just don't sit back in the chair. We allow them to come up toward the front of their chair so they can find the right alignment in their body. Because if they're slumping like this, especially in lung cancer, they can't breathe properly. But if we sit up properly, then our lungs can do the job that they need for us. So I'm going to ask you to slowly close your eyes. And if that's not comfortable, just a soft gaze to the table. Let your hands be in your lap. And let your breath come in and out through your nostrils. Nostril breathing is the proper way to breathe. It is the part of our immune system. It filters the air. It regulates our temperature. So just feel now how when you inhale, how does your body move? Do you move your belly or are you an upper chest breather? It doesn't matter. Everything is fine. But connect with that breath. As it's coming in through your nostrils, does it feel cool? And as it exhales out through your nostrils over the top of your lip, is it a little bit warmer? Connecting the breath to you. This is where we start. This is the start of allowing yourself to heal. Allowing your mind to be quiet for a while and concentrating on you. You are the most important thing. So slowly now, open the eyes. So some of the movements that we do is trying to move all the joints in our body along with muscle. Now, we don't always stay in our chairs. We do stand up behind our chairs for support because we want to work on our balance. But we always start out first with a movement. So let's bring our arms out here and then just bring the fingers down and the fingers up. You're just now moving some joints in your wrist. So pause here and bring the fingers up to the sky and then just go left and right. Doesn't matter how fast you go. We can time this with the breath, which allows the mind to be occupied. But again, we don't have to. And then pause that motion. Now, let one hand just rest. And the other thing we've showed them to do is act like you're turning a knob on your door. That simple turning of the knob on the door. Now switch and do the other hand and turn the knob on your door. You're actually moving muscles without even knowing this. And when I do this with them, all of a sudden they start getting heat in the shoulders and they're realizing, oh, I have shoulders, right? All right. The other thing we do, again, raise the other arm up, put the palm forward and act like you're wiping your mirror or a window, but we make big motions so that way we can use our shoulder joints, our triceps, our biceps. And then pause. And of course, you got to do the other side because if you don't, you're going to be crooked. And I never have any crooked students in my classes. But these are simple things that we do together. We also move our legs. We also twist, and our spinal health is important. So this is what I give to my people. The other word I heard tonight was community. Some of my students, they're by themselves. Their spouses are already gone. Their children don't live nearby. And this is their community. And it also is a community of people that are just like them. They're going through the same challenges, whether that be breast cancer, lung cancer, it doesn't matter. It's a dis-ease in the body. So they are people who can come together and discuss and share with one another. They talk about, oh, I'm on this drug now and boy, it's giving me joint pain. Oh yeah, have you tried, did you talk to your dad? So it's always good to hear from someone else other than your medical professionals, right? To hear from someone who's been down that path. So that's where this community comes in. So we have a program. I'm with Christina Phipps Foundation. We've been a foundation since 2010. We give absolutely free oncology yoga classes. We are anywhere from up to North Carolina, and our southernmost is going to be Orlando. We have a training coming up at Advent and Celebration for yoga teachers to be trained, and hopefully have a lot of classes throughout the area here in Orlando. We normally train 10 to 15 yoga teachers. So we'll want to open classes, and that's why I'm so happy Amanda asked us to come to speak at least of how good chair yoga is, because you tell the patients you need to move, you need to have exercise, and they think, exercise, I can't exercise. They can do yoga. They can do chair yoga. I've seen it. I've seen women who come in on their walkers and they have their oxygen in and they're sitting there and they're moving and they're breathing. It works. On your tables, I did bring out some materials, a small business card. If anyone in the medical profession in your hospitals would like more information about our program and to bring it to your medical place, we would love it. Like I said, we're just now going to train at the end of January, more yoga teachers, and these are certified 200-hour yoga teachers or more. And we would love to have classes available everywhere. We also have Zoom classes for people who do not want to go and be around people at this point in their treatments. And we have a wonderful YouTube channel, which they can go and click on and do it right in their own home. And it has a variety of different places and different types of yoga. So I thank you, and thank you, Amanda, for asking our foundation to come. And please, if you do know someone, hand out the information to them. Everything's there, and we're always here to help. And remember, we're free, always free.
Thank you, Kim. Do you have a program for oncologists?
Well, I have been told they wish they had.
Thank you very much. So I have some questions, but we'll go ahead to our patient advocacy section. So this portion of the program has been pre-recorded. A link to this presentation will be emailed following the program, and we kindly ask attendees to take a moment to watch this very important video recording for patient advocacy and becoming your own advocate. This presentation also discusses current legislative efforts and the barriers and impacts to patient care, presented by Dr. Michael Diaz, FLASCO's Director of Advocacy. Please look to receive this email as a follow-up to tonight's program. So, so we have a few minutes for question and answers, and I'll be happy to take any questions. So let me start with, I've got a couple questions here, and we'll start with this one. How do you work with hospitals when a patient receives an X-ray in the chest and a suspicious spot is found? However, they were diagnosed with an upper respiratory tract infection and discharged, and often these are missed. So that's a great question. So when you do an X-ray and you have a spot in the lungs, and your doctor says that this could be infection or a pneumonia, and here's a course of antibiotics, that's fine. You take a course of antibiotics as prescribed by the doctor, but the key is always follow up. After you take the antibiotics and you're done with the antibiotics, the importance is it's the not following up part where the lung cancers are missed. So you take the prescribed course of antibiotics and you wait, and the symptoms go away, and then you repeat a scan or an X-ray, and if the spot's gone, you're fine. But if the spot's still there, then that needs to be worked up. Okay. So I think the key thing is always follow up. Make sure your primary care physician orders a follow-up, or seek help from your pulmonologist or some of your other doctors in your team to make sure that you follow up and get those follow-up x-rays. Okay, so that's how you can prevent cancers being missed. Any other questions? Yes, please, Tyrell.
So the other thing that, has been a difficult endeavor, but we've tried for the longest to also have a nodule clinic. So in that clinic, let's say you have an abnormal scan, as you said, an AI system tells us, okay, this patient has an abnormal scan. They need to be referred to clinic. They follow up with nurse practitioner. Nurse practitioner tries to help ensure that they don't fall through the cracks, get a repeat scan. When they get their repeat scan, if it's something that requires biopsy, then the goal is to make it easy for them to get into the system to get follow-up. But it's much easier said than it is done. So we've had, a lot of work to try and get that underway. But hopefully, as you say, with better screening, better nodule follow-up, we won't miss so many things.
Thank you. So I know that when we are working in hospital, if there is a solitary nodule, we usually defer that to be followed up by a primary care physician. And that's when I think most of the follow-ups are done. And that's the time range when the follow-up get missed as well. So do you think that whenever nodule is found in a patient, that needs to be worked up while they are admitted or not?
Yeah, so it depends on a variety of factors. So lung nodules are commonly found. The vast majority of lung nodules found on lung cancer screening are actually benign. 96% are benign, or what's called false positives, right? Now, I think there are advanced algorithms that will help you figure out which nodules are malignant, which nodules are benign, and when to biopsy. If it is a lung cancer screening found nodule, there is a criteria called Fleischmann's criteria that's used to help the physician decide whether the nodule is likely to be malignant or not. But I think the key is there are two questions: who has the nodule and the characteristics of the nodule itself, okay? So if you have a nodule, a 1 centimeter nodule in a 25-year-old female who's never smoked, the odds are that that nodule is benign, okay? If you have a 2 centimeter nodule in a 67-year-old male who has smoked for 50 years, that nodule is likely to be suspicious for cancer. So you ask yourself two questions: who has the nodule and what are the characteristics of the nodule? Okay. The size of the nodule is important. Larger the nodule, the higher the probability that it is malignant. Okay. Though that's not always the case. Okay. Most of the nodules less than 8 millimeters are actually benign. Yeah, but you still track them. If you have a 67-year-old male with a 50-pack history of smoking with an 8 millimeter nodule, you don't say, go home, you're fine. You bring him back and say, let's get another scan in 6 months. Okay. And let's take another look at the nodule. Okay. So that follow-up is important, Now the characteristics of the nodule. Some of these nodules may have calcifications, calcium deposits in them, or teacup calcifications, and they look like benign lesions. Generally, if you have calcifications in the nodule, they're likely to be benign. Okay, if they're completely calcium-free, it could be malignant. The nature of the nodule, it could be a nice round ball versus spiculated with thorns like going out. So that's just with human eyes. Now, artificial intelligence systems will do 3D volumetric analysis. They'll look at some 10,000 parameters of those nodules and then try to figure out whether they're malignant or not. Okay, so it's in a evolving science. It's progressively getting better and better. Our tools are getting better and better, but the key is those two fundamental questions: who has the nodule, and what are the characteristics of the nodule that should help you decide what to do next.
The patient has like high risk nodule, then will you work inpatient or like schedule an outpatient follow-up with an oncologist? And I think
Right.
that's when the communication is lost in between.
Right. So the question is, if it's a high risk nodule, what should you do next? Yeah, if it's a high risk nodule, I think you arrange for a biopsy. Okay. And then I think it's communicating to the patient, say, listen, you have a nodule in your lungs. If you're worried that this could be lung cancer, we want to make sure that it is diagnosed and treated properly, because early stage lung cancer is curable. Once the cancer spreads, it becomes incurable. So we want to take care of this before it becomes incurable. Okay. And then you make a follow-up appointment. And for some reason, the follow-up appointment falls through, a clerical error or something like that. That's where you tell the patient you have to advocate for yourself. Call, be a pain, okay? Be a pest and get yourself seen in clinic. If your doctor won't return your calls, find another doctor. There's plenty of us around, okay? So that's where you have to sort of advocate for yourself and be proactive. But most systems are very careful in making sure patients don't fall through. All right, I have another question here. Tyrell, you want to take this? Okay, so I'm going to let Tyrell take this. When the going gets tough, you just pass it on to Tyrell. How is vaping impacting lung health? Are there increased risks for lung cancer with vaping, particularly in our youth or young adults?
Well, I don't think I have a direct answer for you just yet. I know right now we're starting to see some of the effects of younger people vaping with other lung diseases. Whether or not that will translate into cancer risk, I'm not sure. We have that discussion with pulmonologists. They do see, other, water-based diseases that are related to vaping, infections that are, you wouldn't think that young people would have based on vaping. So, I mean, if you just take a gestalt, you would have to think that having, persistent lung damage, whether it be from, whatever the cause, and including vaping in that, I assume that will translate into some type of increase in disease. Whether or not that's a direct increase in lung cancer is yet to be seen, but you have to, think that it may in certain people.
Thank you. Thank you for that. So to detail on that, there is an excellent, when you think about vaping versus smoking, okay? When you vape, you get nicotine. It's a nicotine delivery device. When you smoke, you're smoking for the nicotine, but you get 3,000 other chemicals with it. Benzenes, toluenes, naphthalenes, tetracyclines. I mean, you get a variety of other toxins that come with the nicotine in cigarettes. All they've done in vaping is you've taken out those toxins and you put just the nicotine. You're just getting a nicotine inhalation. Now, in terms of carcinogenesis or the ability to form cancers, right? It is these toxins in cigarettes that actually cause the cancer, right? It's a complex interplay between the toxins in cigarettes and your own genetics and other environmental factors, right? So that's what causes the cancer, the other toxins in the cigarette. Now, vaping doesn't have those other toxins. But there are plenty of evidence in the lab that once you have cancer, or once you have a predisposition for cancer, nicotine can actually make cancers grow faster. Okay. So if you take some cancer cells and you grow them in a petri dish, and in one petri dish, you just give the growth media, and the other petri dish, you give the growth media plus some nicotine, the cells in the petri dish with the nicotine will grow faster. We also know from clinical data that patients with lung cancer who have smoked in the past now got lung cancer, and they quit after the lung cancer has been diagnosed. They do better than patients who don't quit and continue to smoke during their lung cancer. So nicotine may not cause the cancer, but it allows for the accelerated growth of an existing cancer. So one problem. Problem number two with vaping. Okay. It's a gateway to actual smoking. Studies have shown that so teenagers will kid themselves, I'm not going to smoke, I'm going to vape. And a significant proportion of those will not be just satisfied continuing to vape, so they'll start smoking. So, and so that can lead to vaping, can then lead to smoking. That's a problem, okay? Like they say, be smart, don't even start, okay? And then the third problem, which we see in a minority of patients with vapors or teenagers who vape, they can get this weird lung reaction. We still don't, I don't think I understand what that is. They get a pneumonitis and, those kind of things. And it has sent many young, healthy kids to the hospital, sometimes on ventilators for periods of time to get over that crisis. So I don't think vaping is a good idea. Smoking is bad. Vaping is not good. And it's just better to stay away from all of that. Any other questions? We'll hang it up then. And it's.
I just want to give the resources, if it's okay, because I know you asked about it. So there are some general free resources in community. FLASCO is the one being now. They do have resources for education, transportation, financial resources, longevity. It's one of my favorite to go for education. Like now and then, even I go to find, they have a free printable material, like even you give it to the patient. American Cancer Society, they do have a local lodging program when patients traveling. They have multiple support groups. So like patient can log in them virtually, get that support when they're not, feeling to talk. They also have some educational resources, which are written at not higher that medical terms, patient can interpret it. They also have a 24 hours hotline for a patient. So like patient can reach out to them, ask for resources and support. There is also something called a Pearl Point Nutrition. They do provide a free virtual consult for patient for nutrition. It's free, and I like it because not every insurance covers the nutrition. And when patient goes in the community, not every community center has that nutritionist service available. So that's something patient can, explore without having that financial burden. As well as cancer care. Like patient can go in there and get that generous grant for a copay assistant. I have had patient who got thousands of dollars, but yes, there are criteria, like, you have to fit into it, but they also have like disease specific grants, and they can use that grant to get their treatment, alleviate their financial burden. And last not the least, the Florida, since we're talking about smoking, tobacco-free Florida. It's a free resource to every Floridian person. They can go there. They could get all the resources available to help quit smoking. And that's it. Thank you.
Thank you, Kinjal. That's very helpful. If there are no further questions, I would like to end by thanking Amanda Bridges. She has done an outstanding job of organizing this whole meeting, and the hard work she has put in to make this happen is very, very much appreciated. Thank you, Amanda. And I thank you all for joining and being patient with us, and hope you have a great rest of the evening.